Hello, everyone. So today I'm going to talk to you about the informed consent model for gender-affirming care. My name is Dr. Samantha Chow, and I have got a lot to tell you. So hopefully we can blitz through this as quickly as possible while leaving some time for questions at the end. So first of all, we know that informed consent is the cornerstone of healthcare, and gender-affirming treatment is complex, and patients need to be thoroughly informed, and also at the same time, clinicians need to feel protected. Hence this little presentation. I need to declare that I am a trans woman, but I'm also a psychiatrist. And hopefully with those two, I'm able to offer you a balanced perspective, balancing my professional integrity and personal interest. So first, let's start with a brief history about informed consent and where it came from. We need to understand that Western medicine is Greek medicine, and it is historically paternalistic. The old Hippocratic ethic saw the patient as a weak, debilitated, childlike victim incapable of functioning as a moral agent. So back in the days, physicians were encouraged to conceal information from their patients for their benefit because they think the doctor knows best, and physicians and patients were unlikely to have any better ideas. And then things changed when the Nazis came along, and during their reign, they performed unethical medical experiments on people, oftentimes on mentally handicapped people. And from the post-war Nuremberg trials came the Nuremberg Code that gave rise to the concept of what we understand today as informed consent, stating that patients must be able to consent, and they must consent to treatment and or experimentation. They must be free from coercion, and they must comprehend the risks and benefits. Of course, this has later been expanded on by numerous other declarations and reports, and probably not going to go through all of that today. However, despite this, the doctors took a while to join the movement. By the 1980s, only about 85% of doctors are regularly obtaining informed consent. And so the courts had to step in to ensure that this is properly done, which resulted in 3 landmark cases in the US in 1972, Canterbury versus Spence, Cobbs versus Grant, and Wilkinson versus Vesey. In Canterbury versus Spence, the judge said, "The patient's right of self-decision shapes the boundaries of the duty to reveal. That right can be effectively exercised only if the patient possesses enough information to enable an intelligent choice." And now suddenly we're all worried about getting sued. And institutions rush to create forums, and there's been an explosion of interest in the 1970s to 1980s, and this is further expanded by researchers, ethicists, and a drive for equality. And so this is the Medical Council of New Zealand statement on informed consent. You can find that on their website. The New Zealand College of Clinical Psychologists also adhere to their own code of ethics, which can also be found online. So now I'm going to talk about some of the fundamental problems with informed consent and why we struggle with it sometimes. So first of all, what is considered quote unquote adequate information? And the second fundamental problem is, how do we know what is individual or shared information? So the second concern is not very relevant to our discussion today, but you can ask me later if you're interested. So some of you would have known the Kira Bell case in the UK. So she is an assigned female at birth individual. At age 15, she wanted to be a boy. She was seen by the NHS at a Tavistock clinic. She was started on puberty blockers at the age of 16, testosterone age 17, double mastectomy age 20. She detransitioned at the age of 21. And then she took the NHS to the High Court, and the court sided with her. She said she was not adequately informed of, everything that entailed with the whole transitioning process. That was her argument. So what is considered adequate information? So traditionally, we go by the Bolam test, which states that sufficient information is tested against the current opinions of a body of experts. In other words, if a group of doctors perceive information as adequate, then that set of information is considered adequate in general. However, this has been criticized for being too paternalistic. And then there's the prudent person test that came out of Canterbury versus Spence. Canterbury v. Spence, sorry, which state that sufficient information is tested against what a prudent or reasonable patient ought to know. But of course, there comes another problem of what is considered prudent or reasonable. Some patients or some people are more prudent and reasonable than others. And then there is the subjective substantial disclosure rule, which is a rule of disclosing vital information specific to the decision-making process. We need to ask ourselves if disclosing a certain piece of information may or may not change the decision of a particular patient in a particular circumstance. So which one do you use in terms of gender-affirming care? So all three methods have its place. So the Bolam tests are commonly performed with minor procedures, such as donating blood. It allows us to obtain consent quickly from a vast number of patients, so it's very economical. The prudent person test is mostly reserved for less common and more risky procedures, like patient undergoing general anesthesia or there's a major surgery. However, these procedures are generally uncontroversial and well established, whereas the subjective substantial disclosure rule is mainly reserved for rare and often highly costly or risky procedures. This is a time-consuming process and requires intimate knowledge of the patient's values, preference, and life circumstances. So the reality is you probably need to employ all three methods when it comes to gender-affirming care. That really depends on where you work and what kind of resources you have and the kind of patients you come across. So how should you approach this? First of all, you need to know the mental capacity law here in New Zealand. There are 4 criteria to assess a person's mental capacity. First, they must be able to articulate their wishes and preferences, either verbally, in writing, or by other means. They must be able to understand the information provided. In that sense, in that case, being able to understand the nature of the information, appreciate the significance of the information in relation to the patient concerned. They must be able to retain information, although there is a huge caveat in this. They only need to retain information for as long as it takes them to make a decision. In other words, you can consent somebody in the morning and they can forget about it in the afternoon, and that consent is still legal. They must also be able to utilize information to weigh up the pros and cons of their decision. So these are the 4 things that we generally look for in mental capacity law. Therefore, when you're writing your letters, these are the 4 things that you ought to comment on specifically. So here's a quick guide. Step 1, know the patient. Step 2, discuss risks and alternatives. And step 3, document your findings, which is not rocket science. So first step, knowing the patient. Everybody takes a history, right? However, ask yourself these questions. Do I know what my patient wants from me? Do I know the patient's background well enough to know what might be relevant to their decision making? And do my patient exhibit any red flags, such as any prior history of incapacity, any obvious impairment in cognition, any surprising or irrational decision making, or any difficulty establishing trust or rapport? It is okay to take your time. Just explain why to your patient. So, of course, every patient is unique and the list of concerns are endless. So it's really pointless to go through every single risk when not all are relevant. For my case, I designed a readiness assessment tool that I use as a handout. I get patient to fill it out in a waiting room, which often takes them 10 minutes. And that encourages them to think about broad-ranging issues. A lot of my patients have found it very helpful, and they only choose to discuss, selective and relevant concerns. And, when we talk about alternatives, there is often no alternatives to medical transitioning. It's either you do it or you don't. But patients usually want to know how to manage triggers and challenges. For example, how to manage the public toilet situation, how to manage being misgendered in public, if hormones are going to affect their sexual performance, or how to pass, self-protection, or just minority stress in general. And oftentimes they want to know how long is the wait time to await, say, publicly funded services versus paying in private. They want to know if they should wait 20 years or should they just pay $20,000 and get it done and over with in a couple of months. And oftentimes they want to know if they will regret their decision, especially parents are keen to know that. So here are the risks of detransitioning that you should know. First of all, detransitioning means reverting to one's original gender. It is not the same as desisting. So that is a separate topic, which I'm not going to cover today. So I gather my data from a large 2015 US transgender survey, looking at 27,000 plus respondents in an online one-off cross-sectional survey. Half of them roughly are assigned female at birth and the other ones assigned male at birth. So out of the 27,000 respondents, 8% have said they have detransitioned at least once. However, out of that 8%, 62% later retransitioned. Now, trans women were more likely to detransition because they find it much harder to pass and therefore face a lot of discrimination and minority stress. And here are the most commonly cited reason for detransition. Right from the top, 36% of people experience pressure from a parent, followed by transitioning was too hard for them, or they faced too much harassment, trouble getting a job, so on and so forth. And right at the bottom, only about 4 to 5% of people have said that their gender transition was not for them, or that the transition did not reflect the complexity of the gender identity. However, in another smaller study of another online survey of 237 detransitioners, just detransitioners, whereby 92% of them were assigned female at birth, so very heavily skewed towards one direction, although they come from various parts of the Western world, have said their most commonly cited reason for detransitioning is 70% of them said that they realized the gender dysphoria was related to other issues, or related to health concerns, or transition did not help with their dysphoria, or they found alternatives to deal with their dysphoria. Yeah, even a change in political views can make them detransition. So I guess this is a reminder that we ought to be a little bit more cautious when dealing with assigned female at birth people who are looking for detransitioning. So what if I don't pass? So this is often a question I get asked a lot of the times. And again, I draw my data from the USTS survey when they ask their respondents, how often can people tell that you're trans even if you don't disclose your identity? So here, only 2% of them said always, and 10% said most of the time. And that means the vast majority of people can and will pass at least sometimes or most of the time, or most of the times, yeah? So what is the take-home message? So detransitioning is very rare, 8% out of 27,000 people. Most people who detransition would later retransition. And here are the most commonly cited reasons for detransitioning in general. But for people who are assigned female at birth, they have a different set of challenges. Although having said that, most people can pass. So you need to employ all three methods of informed consent. At least this is what I do in my practice. So I'd often give patients standardized information packs, and I design a readiness assessment tool to screen for more specific concerns. It doesn't take them very long to fill out, and it generates a lot of discussion around what they're concerned about. It's a really helpful tool. And of course, I take a good history. I get to know them better, sometimes over 1 or 2 sessions, and I discuss alternatives as appropriate. So documentation is very important. I would advise you to use consent forms wherever possible. Also write very good clinical notes, such as, notes that refer to the patients by their preferred name and pronouns. Clearly documenting their goals and sought after treatment, show evidence that you have taken a good history, comment on their mental capacity according to the 4 legal requirements I have stated earlier. And of course, state in unambiguous terms what your recommendations are. Okay, I cannot stress this enough. It's either a yes or a no, not maybe this or maybe that. I think, patients find it very unhelpful, and clinicians too. So now comes the most interesting part of the discussion. We talk about the morality and ethics of the informed consent. So first things first, ethics are not morals, okay? So ethics, in this case, biomedical ethics, is a system of thought that rests on 4 pillars. That is the pillar of autonomy, beneficence, non-maleficence, and justice. Every one of us who has been to medical school will understand and know this. However, morals are emotive. They have evolutionary and genetic origins, and a lot of it is cultural as well. They're generally considered to have 6 they are generally considered to have 6 moral foundations in humans, according to the moral foundations theory. So what are the common ethical concerns when we're talking about gender-affirming care? A lot of that applies to young or even maybe vulnerable individuals. Critics will say that these people cannot consent to treatment because they cannot appreciate the risk, even if informed, due to a lack in frontal lobe development or life experience in general. Skeptics are more likely to believe that they are influenced by illness or media or parents or culture, therefore they are not independent thinkers. Some have argued that the benefits of treatment are not proven, although that is not true. I have lots of studies that prove that treatment is very helpful. And longitudinal studies have showed an increased morbidity and mortality, although none of them have actually been able to point out why. Is it because of the treatment itself or minority stress? Nobody has actually looked into this as far as I'm concerned. So let's break them down. So I think we need to ask, in earnest, should people have control over their bodies? Should can teenagers have an abortion, for example, or a piercing or tattoo, or can they drink alcohol? How do we inform people about a future that hasn't taken place? And what does it mean to appreciate risk, quote unquote, appreciate risk? Also, what do people have to do specifically to demonstrate that they can appreciate risk? And is the appreciation of risks all there is to decision making, or should people be allowed to make risky decisions as long as it doesn't hurt other people? So these are important questions to address before we proceed. And when we're talking about beneficence and non-maleficence, we have to ask, to whom does it benefit? And based on what standard, how do you measure these things? And how much does treatment itself contribute to adverse outcomes as opposed to stigma? And why do we ought to control treatment but not stigma from society? Again, key points, key questions. And it pays to appreciate the fact that there are always 2 sides to a coin. For example, skeptics often tell me that there's no evidence that informed consent model is better. But the last time I look at things, the gatekeeping model is also not really good. Treating these people may cause more harm than good, according to longitudinal studies, but doing nothing is just as, if not more, destructive. And a lot of clinicians are worried that they will face criticism if they do something wrong, but then a lot of them will also face backlash if they did nothing. So what now? So we need to understand that our morality determines our ethics. Fearful clinicians are more likely to protect themselves more than their patients because they're afraid of being litigated. And therefore, they tend to fall back on the gatekeeping model as opposed to focusing on individualized treatment, because they start prioritizing this lower prioritization of patient autonomy, and they start to deny access to treatment. But it's understandable because I'm a clinician myself. What makes me afraid is if I'm unable to protect myself from legal ramifications or social persecution. Because when something bad happens, patients often claim that they're not adequately informed, and this is difficult if we don't document our findings, our notes very well. And if, and conservative media tends to go crazy with these news, and which leaves our professional career in integrity in jeopardy. But oftentimes when something good happens, nobody talks about it. Patients don't complain. There's no attention paid on media, and we just believe that we got lucky, which is actually not the case. So how do we conquer our fears? So look, first of all, we need to understand that it is very normal to be afraid when dealing with something as complex as this. There are some simple heuristics that I always fall back on. That is, when in doubt, just discuss it with your colleagues, go slow with your treatment, have regular follow-up, family involvement, and often review and change treatment plans, when necessary. Now, I know this is difficult for isolated practitioners who work in small centers whereby they don't have a lot of colleagues to discuss issues with. I guess in this case, we're trying our best to network with people from around the country so we can provide everybody with supervision or peer review as necessary. And always, have professional and personal support. For example, try to stay up to date with the literature as much as possible. Join a peer supervision group, have really good boundaries, and, when all else fails, just back out if it gets too much. And then comes the important question of, can doctors be conscientious objectors? And the answer is yes. So the New Zealand Bill of Rights have said that everyone has the right to freedom of thought, conscience, religion, and belief, including the right to adopt and hold opinions without interference, although doctors have no right to refuse medical assistance in dying, abortion, or contraception. So those are the three exceptions. So far, there's no provision for gender-affirming care in the Bill of Rights. Therefore, clinicians still have the freedom to deny treatment based on a conscientious objection. But you have to tell your patients why, though. But strictly speaking, the informed consent model does not take into account clinician preferences, feelings, moral integrity, or conscience. Even the New Zealand Medical Council on Informed Consent states, if you are worried that your patient is making a decision that is not in your best interest, you should explain your concerns clearly to them and outline the possible consequences of their decision. Where possible, work with the patient and their whānau to find a solution that works for them. There's no mention of denying or withholding treatment unless a patient lacks capacity, although you still can based on a conscientious objection. But we need to understand before we object to treatment, we are biased ourselves. For example, I found this article about the traumatic process of young women needing hysterectomies. So a young woman who needed a hysterectomy to treat chronic endometriosis has detailed the traumatic process she had to go through with a surgeon who told her she had a responsibility to reproduce. She had clearance from a psychologist, but her surgeon pushed back. He had received a letter from the clinical psychologist, and he still tried to deny it and was just very determined that as a woman, I have this ability and responsibility to reproduce. After reluctantly agreeing to the surgery, he said something that has always stuck with her. He said that he would cry for me on the operating table, and that made me feel really guilty about the whole thing. So one of the problems of bringing paternalism into this is that we think that you don't know what you want, and therefore we're trying to stop you from having something because of the potential that you'll want children in the future. And if we do that, we miss the point of actually looking after the person. Removing the uterus does not stop someone from being able to have children, she said. So this sort of bias is the same kind of bias that we face in gender-affirming care. So although it is important to be able to object conscientiously, and there are times when we have to, it's important that this is important to set limits and boundaries so we can protect ourselves from being coerced into doing something that we don't want to. We also need to be able to object so that we can protect patients from other powerful entities like the state. But very importantly, we also need to know where to draw the line. And lastly, we also need to consider broader social cultural forces. So here's a Venn diagram that I've drawn up, which with 3 standards from a clinician and patient and societal point of view. So from a clinician's point of view, as long as the patient has capacity and the clinician has resources and whatever treatment has evidence base, then it's okay for them to go ahead. And from a patient standpoint, as far as they are an independent thinker or they know what they want, they're doing it for their own benefit. And, society will ask questions like, can children or the mentally ill consent to something like this? Or can people decide what to do with their bodies? Or should taxpayer fund for quote unquote cosmetic surgeries? Or does this conform to the prevailing culture, politics, and religion? So if you operate in this region, then obviously there's no patient consent. And this region means that no patient participation. And if you operate within here, then, obviously it is frowned upon by society. So ideally, you want to operate within this little tiny zone, this home run zone, where the clinician is okay with it and patients asking for it and society is okay with it too. But in medicine, it's not oftentimes that straightforward. And the informed consent model of care falls within this region, where although the clinician and the patient may agree to go ahead, not everybody in society is happy with what we're doing. So we need to be realistic and have a perspective. If you do this long enough, eventually you will encounter a complex patient and you will eventually be targeted by conservative groups or unhappy parents or patients. But this is just the nature of our jobs. Well, I think we're safe for now, as long as New Zealand remains fairly united and progressive, as long as the government continues to publicly fund the treatment, as long as professional bodies like the colleges and the New Zealand Medical Council continue to support us in delivering care, and the media has to play ball as well. And as long as we don't hold a referendum on this, I'm not very confident that it will turn out okay. I think if we're able to do all this, we're probably safe here in New Zealand. So in summary, I've given you a brief history of how informed consent came about. I've talked to you about how to obtain informed consent with gender-affirming treatment, some of the problems and limitations with informed consent and how to overcome them, the risks of detransitioning and the risk of not passing. We talked about the ethics and morality of informed consent. And finally, we talked about some of the broader social cultural considerations. And that's it. Thank you very much.